So today we're going to talk about what is the healthcare safety net and who's kind of involved in the healthcare safety net, and then why hopefully I can kind of explain throughout the presentation why this is important to you and your company. And just thank you for being interested in serving the safety net. That and in and of itself is really something valuable to all of us and admirable. So thank you. Next slide. So what is the safety net that we're talking about? You know, it's funny. I was just helping someone apply for Medicaid the other day. I do that on the side because I run into people all the time that don't even know these benefits are available to them. And what I was explaining to him, he lost his job and then he fell off a ladder. And now he has, really bad medical bills. I don't even want to guess what he's going to get charged. But what I told him is that he can actually apply for Medicaid and they backdate at 90 days. And so actually, if he can get on Medicaid, they would pay for his hospital costs. And what I explained to him is that this is your safety net. You pay taxes. The reason that we do this as a culture is to have a safety net for all of us when we need it. I've had multiple people in my family be on Medicaid in the past. It's here for all of us, and you never know when you're going to need it. So I really do think of it as a safety net. Who it ends up serving, though, is our lowest income people in society. And poverty goes hand in hand with health disparities. So often we see people who are low income have higher health needs. And I won't go into, I looked at the list of your companies and the solutions you're working on, and I can tell many of you are familiar with health disparities and the impact it has on people in our communities. So I won't go too far in depth on that, but we know that discrimination and poverty have led to significant health disparities in our country. And we saw that in COVID, right? It was one of the silver linings that it really brought light to the problems we have in our health system. So the safety net is in all of our communities. So Denver Health, well, I'm sorry, we're in California right now. I was thinking of our big safety net system, yours in California, that every community has that safety net hospital that barely gets by paying its bills. We're bailing out Denver Health. The legislature is this legislative session. And there's clinics too. And we'll talk about all the different types of institutions, but they deliver the healthcare to people who are on Medicaid, but also people who are uninsured. And there's a lot of uninsured people who should be on Medicaid, but don't get me started on that. And other vulnerable patients. So think about immigrants who there's a 5-year ban when you're an immigrant before you can get on Medicaid. So these are the safety net is the system that serves all of the people who don't have commercial healthcare coverage, basically. Next slide. So here's the different government healthcare programs. It can be really a lot. I'll talk about how to tell the difference between Medicare and Medicaid in a moment. There's a little trick that we like to use, but Medicaid's for low income. Medicare is for people 65 and older. Children's health insurance plan, a lot of people don't know about this, but it's just right after Medicaid. So if you make a little bit too much money to be on Medicaid, your kids can be eligible for what we call CHIP. Indian Health Services is a little deal that the government made with Native Americans when they took all their land a long time ago. Not a fair deal, but Indian Health Services is for Native Americans. The TRICARE is for all of our service members, and actually is a pretty excellent healthcare system as far as healthcare systems go, public healthcare systems. And the long-term services supports is another benefit that you can get in Medicaid if you're really sick. So it's for people who are disabled, whether it's a physical or intellectual disability. And it is, these are our sickest members in our community, sickest and poorest people. Next slide. So Way back when I started working on healthcare policy, someone told me that the way to remember the difference between Medicare and Medicaid is Medicaid ends with aid for low income people. Medicare is care, and it's care for people who are 65 and older. So good luck. I don't know if that's helpful, but it's fine. People get this confused. It's okay. Don't be hard on yourself. It's a freaking mess. And it's a full-time job for me. So I'm a consultant now, and I help people with all of this mayhem to try and make changes and improve our system. And but you're going to need to know some basic information, and that's why you're here today. So kids, pregnant people, people with disabilities, people who are elderly. So you can be on Medicaid and Medicare at the same time. We call these people dual eligible, really low income and over 65, or have a disability. So yeah, that's your slide on Medicare, Medicaid. Let's see what's next. Oh, I do want to say, well, we'll talk about Medicaid a little bit more. So 1 in 4 Americans are enrolled in Medicaid. So I'm like, hello, people. It's really important to understand that 1/4 of our community is enrolled in Medicaid, and people don't understand that. So I want to impress that upon you. The next slide, I think, shows the enrollment. So the pandemic, we put a lot of people on Medicaid, and we kept them on there throughout the pandemic. So this slide is from when the pandemic was still happening. We saw a tremendous increase in Medicaid enrollment because so many people lost their jobs. And then Congress decided, let's lock people into healthcare, keep them on Medicaid during the pandemic. In 2023, you'll see what happened on the next slide. We actually started to disenroll people. We started to check eligibility again, and you may hear about this in the news. It's a huge issue right now. A lot of people are losing Medicaid eligibility, not because they're making too much money, but because they didn't submit their renewal packet. And it's bad everywhere, because I always pitch this to entrepreneurs, like, please find a solution for getting people signed up and into Medicaid quickly, and then renewing their eligibility, because people get something in the mail, they set it aside, they don't complete their paperwork, and then they open it and it's like 20 pages long because there's all these federal requirements. Don't get me started on that. Or they forget to sign it, or they don't ever get it because they've had housing instability and they haven't updated their address with the state. So we're seeing a lot of what we call procedural denials, people losing Medicaid right now. So I just mentioned that small policy issue because it may be something you're hearing about, and you can see the dramatic drop in enrollment in Medicaid. And there's just a lot still to play out with that. I think actually this is going to shine some light on the need to improve our application and renewal process, which is something that I've been trying to work on my entire career. And I would love to see some changes, like, I don't know, like automating it, maybe some AI so people don't have to answer every single question if it doesn't apply to them, all kinds of stuff. Anyways, let's move on to the next slide. So the key point is, I always say, once you've seen one Medicaid program, you've seen one Medicaid program. So that's the other thing that makes your job hard, is that every state has flexibility. So Medicaid is a federal and state program. So it's, I hate to say percentages, but broadly, it's 50% funded by the feds and 50% funded by the state. Although those percentages change dramatically based on population and legislation that passes and things like that. For example, CHIP is sometimes 60% funded by the feds, but the state, because they're putting their own funds up, has some authority to be creative in how they deliver their Medicaid program. And I always say that Medicaid, and it's true, Medicaid is the hotbed of innovation in healthcare in this nation, because there's so much flexibility and there's so many states trying different things. And then there's this whole CMS Innovation Academy. So it's like, I've worked on a lot of innovative things in Medicaid that doesn't happen in commercial, and we're ahead on a lot of things that commercial ends up adopting after us. So, but it makes your job hard. As I said, you need to understand how the state reimburses. Most states do managed care, but they can do managed care for physical health care and not behavioral health, or vice versa. So that's a whole thing. And then healthcare is local, right? So Medicaid contracts with local providers. And so if you really want to get into the Medicaid game in a state, you kind of need to learn more about the providers in that state and the climate in that state and what are the top, healthcare needs in the state and things like that. So next slide. So just to demonstrate how poor you have to be, and California actually has pretty high um, coverage levels. So you've heard a lot about Medicaid expansion probably through the Affordable Care Act. Not every state had to expand. They're stupid not to, honestly, because 90% of the expansion population is funded by the feds. And when people have healthcare coverage, they don't go to the emergency room as much, and they have healthcare coverage, so that's paid for. And so anyways, long story, but um, California has a higher threshold. They expanded Medicaid. And so higher income people, if you want to call this higher income, qualify for Medicaid, but you still have to be pretty damn poor. So, family size of one, $1,400 a month, and you qualify for Medicaid. So hopefully that gives you some context. Most people, there's just a lot of families on Medicaid. And they're all working, by the way, to be clear. There's a lot of research that shows, 70, 80% of people enrolled in Medicaid are actually working. They just not making any money, minimum wage. Okay, so next slide. So I mentioned whether you're an expansion state or not, I mean, states do have some ability to decide how many people they're going to cover and to add different populations into Medicaid that they want to cover. So it's always really good to look and see what the state's doing that you're interested in. And so this just shows you the percentage of Medicaid and CHIP enrollees by state. And you'll see typically higher enrollment levels in the South, where people are lower income. So yeah. And then Medicaid's, Texas is really low enrollment because they haven't expanded Medicaid. So they've got a ton of uninsured people in Texas. Okay, next slide. I mentioned that states really have a lot of flexibility in how they deliver Medicaid, and I could go like really in the weeds on this, but I won't. But you can choose if you want to do like an ACO like model versus a managed care model. And that's as far as I'll go with that. But things like that, what you emphasize, what you focus on, if you decide I want to work on behavioral health, I want to put money in on the front side to do more prevention, or we as a state want to focus on chronic conditions. All of that ends up factoring into how much money each state spends on a Medicaid beneficiary. How much are they spending on benefits? And if they decide not to spend money on the front end, they'll be like South Carolina, that average spending is $4,100. But they may pay for that on the other end by not really addressing people's healthcare needs and getting them all the benefits and services that they're eligible for, and seeing more sicker people needing hospital care. And Medicaid still has to pay for that, right? Because they're enrolled. So anyways, there's a ton of variation in how much money each state spends on Medicaid. And it's something that people really, leaders really pay very, very close attention to. Okay. And then it's how sick is your population? That's another thing to think about is, we see sicker people in different parts of the country. So you can, and it's usually corresponding with income level and ethnicity. And, like I said, you can decide what kind of benefits you cover. So I think I beat that one. So next slide, Nico. Okay, so here's the mandatory benefits if you're going to offer a Medicaid program, which every state does. These are the services that have to be covered. your typical hospital things, but also primary care, specialty care, behavioral health. So I worked on that when I worked on the Affordable Care Act. We actually expanded the mandatory benefits. We said we're going to give the states a bunch of money to expand Medicaid, but if they do, they need to cover certain benefits. Here's all the benefits that they have to cover. I think dental and vision might have also been added through the ACA, but I can't remember. But you see it's for kids. So like Colorado is a good example. We added dental for adults a few years back. That's big, really big. I bet California covers a bunch of great stuff. Optional benefits, but there's a lot more actually that can be added. So that, like I said, the states have a lot of flexibility, but that's a bunch of drama, right? It's benefits can be added, but it takes legislation, state legislation, and it's expensive, and there can be a battle at the legislature about that. So next slide. This is just showing you the maze, and I just, I don't know if you want to pay too much attention to this because it's like really daunting. But we've got Health and Human Services, right, which is a cabinet agency. The president appoints the secretary. And then underneath Health and Human Services is all of these other agencies. One of them is the Center for Medicare and Medicaid Services, CMS, and they oversee Medicare and Medicaid. And there's just like hundreds of thousands of employees in all of these agencies. But there's a lot of really other important agencies. The FDA, you've heard a lot about, approving drugs. Institutes of Health, really cool research. IHS is Indian Health Services. CDC was really important, obviously, during the pandemic. Center for Disease Control. ARC is a great place to go and get funding, because they do a bunch of research and like to support grants and things in the community. Same thing with SAMHSA, but they focus on behavioral health. ONC is technology, so you might be interested in that. Yeah, it's a lot. I can't believe I know what all those are. HRSA is also research. So it's just a lot. And I wouldn't stress too much about this, but you'll hear a lot about CMS. They are the deciders. So even when the state, say, passes a law to add benefits, then they have to go to the feds to get permission. And that's a whole other web. Yeah. So let's do the next slide. Okay, this is really, really important, and why I hope that you're here, why I'm really active and sometimes obnoxious as a board member of Prime, and that is the providers. Because these are the folks that have made a decision to serve the safety net, and they've made a business decision to do that, and it's fine. It makes their jobs very hard because Medicaid doesn't pay the full cost of delivering services. I'm happy to talk more about that. Medicare pays a little bit more, but as a result of Medicaid not paying the full cost, not all providers will serve Medicaid, right? So this is always a thing. We're always recruiting more providers, and there's a shortage of providers that will serve Medicaid. And there's also stigma and people's false beliefs about Medicaid enrollees. So these are the folks that actually care, that are actually serving Medicaid. And I want to make a distinction between your first group here, the federally qualified health centers. They get federal funding, and they often have really nice clinics because of the federal funding. And they're actually, a lot of them integrated. These are your partners. These are great partners for you because they have resources and they're integrated and they're looking to do innovative things. So always keep your eye out for the FQHCs. I want to make a distinction between them and the third group down here, the community safety net clinics. These are the clinics I worked with a lot that don't get federal funding, but still serve the uninsured. And there's a lot of reasons it's hard to become a federally qualified health center. There's a lot of hoops and a lot of things you have to do with your clinic to get there. So these community safety net clinics are the ones that I think we need to help the most. And they serve not only both FQHCs as the federally qualified health centers and regular community safety net clinics serve the uninsured as well as Medicaid. So they're key members, usually primary care, but a lot of them, FQHCs also do dental right there in their clinic and behavioral health. And they have like care navigators, care coordinators to connect people with social health related needs, health related social needs. Is that the term we're using these days? I know social determinants of health is like out health related needs, social health, whatever's in. So community mental health centers are also an awesome place to partner because they get a lot of federal funding and are pretty advanced. And these guys are actually the ones that treat a lot of social needs, because when people come in with mental health issues, there's a lot of social reasons and a social factors. So they have been working on housing, food instability, domestic violence, issues like that for longer than even primary care. So another great place to partner. Dental clinics, we don't have enough. I mean, it's just very few dentists will serve Medicaid. So I always, when I go to my, if you go to go to your dentist, ask them if they serve Medicaid. If they don't, go to a different dentist. That's what I say. Critical access hospitals. These are the hospitals, especially in rural areas, that you hear about maybe closing their doors and cutting back services. I know in Colorado, we just saw a bunch of hospitals stop providing maternal care, if you can believe that, because it's not a cost center. At the end of the day, if it doesn't make money, we are vulnerable to the services not being provided. Emergency departments, obviously, this is the catch-all where everybody goes. You probably know that. I was talking about the public hospitals. Be nice to them. They're the saints of our community. Public health agencies, you wouldn't know this, but they actually do provide a lot of preventive care, a lot of family planning services, rural health clinics. Again, very similar to the community safety net clinics, although they do get some federal funds, but they're key. And then a lot of people may not know, but school-based health centers, one of my favorite clinics because they catch kids at school, because a lot of the times people don't know that they're even eligible for Medicaid. Once they're on Medicaid, they don't even know what their benefits are. And so they're just not getting care. So a lot of my projects in the past have been like, let's go through the school-based health clinics and catch them at school and do a lot of preventive care there. And they're doing a lot of cool stuff, delivering all kinds of integrated care, not just physical health care these days. So, all right, am I done, Nico? Yes.
Done with slides. Certainly not done with content.
I hate going on and on and on and on. So I hope that was helpful, and I'm happy to answer questions.
We have a few great questions from the audience, but I'm selfishly wanting to start off with a juicy one that I have always been fascinated with. And in my experience, I have seen the impact of the innovation programs that CMS has really led the way with. When we talk about the movement towards value-based care, that is largely a CMS-driven activity with different programs that they've come up with. And in the innovation space, a lot of ideas around digital health companies come from just going into a healthcare setting and saying there's got to be a better way, and coming up with a technology solution or a business model innovation that can deliver that better way. But oftentimes that solution is tied to kind of a value-based model. And so if the government, if CMS through Medicare and Medicaid is leading the way in these innovative programs, and we have companies that need that value-based approach to make it make sense for our solution to be adopted, how do we get involved in that? And is it really just a hyper local thing where I have to figure out what's going on in this community before I can plug my solution into that? How would you advise a company like looking at that broad and diverse landscape?
Wow, that's a great question, Nico. And there's like, it's a long answer, so I'll try and be short. You're exactly right. In a lot of ways that the Innovation Academy out of CMS has led the charge for value-based payment for many years, actually, and states have taken them up, providers have taken them up, and really you almost always, not almost always, because I think there are solutions that can get fee-for-service reimbursement in certain circumstances, depending on your solution. And I've helped I've seen that happen. But a lot of the time you need that value-based payment, because the value-based payment is a comprehensive payment. So it's often the times it's upfront and it's a pot of money, and the provider will get it, and then they decide what to do with that pot of money, and they can take that pot of money and use part of it to pay for your solution. And and the way it works is that if they're successful in delivering care, they get to keep, and they don't have to spend that whole pot of money on that patient, because they've done a good job and there's a healthy outcome. Then they get to keep that as revenue, the rest of that money. So that's a very crude explanation of it. And the way to get involved, and that's the hard part of this, is it is pretty local, unfortunately. Knowing your market, knowing your Medicaid program. So, but you look at any Medicaid program across the country, their website, they've got value-based purchasing initiatives underway. They're working with stakeholders to develop a value-based payment. They're at various stages. It's relatively new, so you won't see value-based payment broadly across the country, and that's what's a struggle for all of you, is that it's kind of in a nascent stage to some degree across the country. But there are some more sophisticated Medicaid agencies, but doing some interesting things. I know it's always a struggle for entrepreneurs, because it's like you almost need like a policy person that can track what's going on, get to the table. There's also ways to get involved on the federal level, and work directly with the agencies as they're developing these innovations. But I just don't think you probably have the resources for that. So, from my perspective, what I would do is I would try and learn a little bit about what's happening at the Medicaid agency in the state you're interested in, but also look at the big providers, the big Medicaid providers, and try and meet with them and see where they're at in engaging. Because these big Medicaid providers, FQHCs, they're all engaged with the state Medicaid agency. They can tell you what's happening with value-based payment. It's their bottom line, so they are engaged. Now, the lesser resource clinics may not be, but the bigger providers will be, and they can kind of tell you where things are at with payment changing. But don't let this be a barrier to you. I think it's going to your potential partners and making your case and letting them figure out how to fund you. And of course, you can ask the questions. Are you aware of any payment changes that might make it easier for you? But let them figure it out, because I'll tell you one thing is that these safety net providers are resourceful. They've had to figure it out for many years to do all the things they want to do. So don't underestimate them, I guess I would say. So I hope that was helpful.
Yeah, yeah. And that totally goes along with our last session. We talked a lot about business development and this collaborative approach to working with customers around, being open and honest about what you know and what you don't know. And you might not know how they would ever pay for something like your solution, but being honest about it and open to the collaboration, I think can go a long way in that space.
Yes. And to that point, Nico, I would say be humble, right? It's okay that you don't know healthcare. That's not your job. And that's actually why you're bringing something cool, because you're not mired in all this crap we've been working on forever. Your brain works differently. So I would just humbly approach people and say, we think this might help you. How can we learn more? How can we, how can we be helpful to your organization? And don't come in with I know everything about healthcare, because they don't even know everything about healthcare. So they'll call you bluff on that.
Nice. Let's get to some of the questions in the chat here. So Ryan, you had first dibs last time, so I'm booting you to the back. Catherine, do you want to ask your question about benefits? Yeah.
Yeah, since Medicaid is, federal, but each state gets to kind of set their own levels, and some are Medicaid expansion states and some are not. Is there some handy way to know, like which of the optional benefits each state has committed to, and more importantly, what the reimbursement rates are for things. I mean, the one thought that I had specifically was around telehealth, right? And making those telehealth benefits like permanent. But in general, is there like an easy way to figure that out?
I don't think it's easy. So I love Kaiser, the Kaiser Family Foundation. I love their research, and they have a lot of state by state comparisons. So I would start on their website. Also, you can, I mean, if you want to dig into the Centers for Medicare and Medicaid Services, like every state agency has to report their data and their information to CMS. So they also are a place to look. It's not the easiest, unfortunately. But you know, if you're talking to don't be afraid to contact the Medicaid agency. A lot of the times they'll reply and just say, where do I find this? You know, just go to the ask us a question thing. I mean, people are intimidated or they think they won't get a reply, but a lot of times you will. I should have mentioned, I've worked inside of 2 Medicaid agencies and led innovations and implementations there. So I know a lot about what's going on inside there. And it's a bunch of public servants who really care about what they're doing, and they're underpaid and overworked. But anyways, I would not hesitate to ask them. On telehealth, crazy things going on right now on the federal level. We've got to get an extension of the telehealth that we got out of the pandemic, and that's something that Congress is talking about right now. So there's still a lot to play out, but a lot of states have continued the telehealth flexibilities. I bet California has, but it's a difficult thing to look into, but those are the kind of where I would start, and I'd welcome anybody else if they have better ideas to chime in.
Nice. And just, sorry, Catherine. Just as a preview, our next guest is actually the director of telehealth programs for HealthNet California, the Medicaid agency there. So we can definitely go a lot deeper on that in the next session. I want to ask Stephanie if you'd like to ask your question.
Can I just 1 second, 10 more seconds on that last topic? I don't know if you all have already seen this or if this is too obvious, but I just did some like really quick Googling the last 5 minutes and dropped a couple links in the chat that I thought were cool. Medicaid has like a map that you can click on each state and see like who took the expansion and who's doing CHIP and whatever. So like that's kind of helpful. If you dig around in their links, they really do have, it's very dense. So I don't know if it's specifically what you're looking for, but there's a lot there if you feel like digging and have the time.
Sweet. Thanks, Darby. Okay, Stephanie, are you a catalyst?
Yes,
right now?
I'm here. I am a catalyst.
Oh
Yep.
my gosh.
All right,
Cool.
I'm assuming you're not there.
No.
Anyway, thank you, Elizabeth. I definitely learned we're in charge with all of the organizations. There were for sure some new ones on there for me. So my question was about who is considered a safety net provider, and is there like an official, I am either a safety net provider or I'm not, especially for large health systems where they might have an emergency department, right, that is serving the community, but broadly they are for profit or not for profit, but very profitable, maybe academic. Would they still be considered a safety net? And how do you kind of know overall?
That's a great question. There is no like official like designation. I'm glad you mentioned the academic institutions because some of them do serve Medicaid and some of them do not. And then some of them partially serve Medicaid. So sometimes you'll see like a university healthcare system that will have clinics, primary care clinics that serve Medicaid and uninsured, but they have specialty doctors that don't. And so that's often a battle the Medicaid agencies are trying to get the university to share their specialists. But that list of providers that I covered in the last slide, all of those will be, those are safety net clinics and safety net providers. Every FQHC, every rural health clinic, every public hospital. If you're a nonprofit, a lot of the times you're serving Medicaid. You'll see for-profit hospitals that won't serve Medicaid. And I just want to be clear, there's this thing called EMTALA that we have to keep a civilized society, that, you know, if you are about to die and you go into a hospital, it doesn't matter whether you're insured or not, we will save your life. So that's a nice thing. But, you know, actually a lot of people die in our country because they can't get further care. So I won't go into that, but your life will be saved under EMTALA. You know, you can just ask the institution. There's a bunch of private clinics that only serve commercial or only serve Medicare. Hundreds of doctors' offices where it's just that doctor, or you know, 4 or 5 doctors working in a clinic together that will not serve Medicaid. And there's tons of those. And they're just private clinics and they choose not to serve Medicaid. So I'm sorry, I don't have there's no hat or anything like that they wear. So
Awesome. Thanks.
I'm sure you could find a list though in your state of like safety net providers. If it, you know, Darby's good at Googling, but I think, you know, you can go to the federally qualified. There's an association for there's a hospital association in every state. There's a federally qualified health center association for every state. A lot of the times there's a health plan association. And on those websites, you'll get the list of providers. And if they're one of those providers on our last slide, association for that group, then they're going to serve Medicaid.
Yeah. One of the places that so I know for sure in Colorado, I've spent a ton of time obviously looking through those lists. And I would imagine it's similar in other states, but all these facilities are licensed and registered, right? So that means they're on a list. That means they're in the database, and that means they have a tag. Are they an FAQHC? Are they a CAH? Like, there's a designation of what type of facility it is. And if you dig into those spreadsheets and get into your state websites, that information should be publicly available. And if it's not, then you send somebody an email and they'll have to get it to you at some point.
All of these challenges in working in Medicaid and the intricacies of it are actually barriers to entry for other people. So if you can put in the effort to learn this, there's a lot of good that you can have and a lot of impact that you can have if you can get through it. So it's a high ticket to get in, but once you're in, it can be a really great place to serve. Thea, do you want to ask your question?
Yes, thanks, Nico. Hi, Elizabeth. Quick question as it relates to the maternal health. I know you stated that specific healthcare sectors were leaning towards just getting away from that space in the coverage. So just want to know what specific healthcare sectors those were.
I'm trying to remember what context I said that in. So, I mean, we've always struggled with getting providers to serve Medicaid, but then we did the Medicaid expansion, and 1 in 4 Americans are on Medicaid now. So honestly, if you're a provider, a lot of the times, depending on the makeup of your community, it makes financial sense to serve Medicaid. So we're actually seeing more providers get into Medicaid now than ever before. But there are shortage areas. So our biggest shortages are in behavioral health, in providers and in institutions. And that's kind of a nationwide problem, and across healthcare systems, and, you know, on the commercial side too. But one of the biggest areas that I see is like inpatient psych, inpatient substance use rehab. Those are 2 areas where there's not a lot of money to be made. There's not a lot of reimbursement. And so we really struggle to get hospitals to offer that. I mentioned some hospitals in Colorado have stopped offering like maternity care, like delivery, which is crazy to me because that's always been a cost center. So many births. So I'm not sure exactly what's going on with that, but anytime providers don't feel like there's enough reimbursement, they don't offer it. Long-term services and supports is another area where we just don't have enough providers, and dental. So hopefully that's helpful to you.
Yeah, thank you for that. Good insight. Thank you.
Okay, Pitts, it looks like you have a two questions here if you want to ask those. Pitts, are you with us? You weren't with us earlier for introductions either, but you seem active.
Maybe
Okay.
Pitts is having a technical audio issue.
Yeah.
I can read the questions if you want to do that, or we can go on to a different one.
Yeah, go for it. You can play Pitts, Darby.
Yeah. Hi, I'll be playing the part of Pitts for the next 30 seconds. Great questions. The first is, what is the best way to engage TriNet and Indian health systems? And then also, what are the top 3 reasons states refuse to expand Medicaid, which I think is probably quite a long answer that we may not have time for. Let's start.
Okay. I tend to forget second question, so I'll let you know if I forget,
Okay.
Darby. But
TriNet and Indian health systems. Let's start with that one.
yeah, so TriNet, I think they mean TRICARE. TriNet might be a name of might have been on that slide though, because it might be a name of a health plan inside the TRICARE system. So TRICARE, as a reminder, is the system that serves veterans and families in the service. And although there's some concerns about, there's always problems with all of the health systems, but it's one of the better, more integrated systems. And Indian Health Services, that's a great question because they're both federally administered, which I should have been really clear about. The feds administer TRICARE and IHS, not the states. So your Medicaid agency does not play a role in Indian Health Services. So the best way to go for those two are going through your Centers for Medicare and Medicaid Services. And I actually don't know a ton about those areas because I haven't worked in them. But there's always ways to get involved on the federal level. It's actually easier than you think it is. They have stakeholder meetings. I mean, it feels daunting and intimidating, but it's actually not. They're just people like us. And they have to have stakeholder meetings and meet with the community and let you weigh in. And they have public comment periods and let you weigh in on all kinds of things. And it's a whole career if you're interested. But that's where I would go for both of those. And IHS, if you're, comfortable approaching the tribes, I've always actually really enjoyed just learning a ton about how healthcare is delivered on the reservation, and there's just lots of problems and cultural problems with cultural competency and really understanding the culture and delivering healthcare well there. But approaching the tribes has always been really enlightening to me. And they have offices where they deliver IHS services on their reservation. And you can go visit those offices. And they've got an administrator that works with the feds and they partner. And they actually do really cool stuff. So I would not be afraid to go and talk to those clinics directly too. That's another way. And I guess same thing with TRICARE. Like if you know a clinic, there's a lot of clinics that serve primarily veterans. You can go to that clinic too. And if it's a larger clinic, chances are they're tracking on policy issues on the federal level with TRICARE.
Awesome. And then the next part to that question was, if you could enlighten us on some of the top reasons that states refuse to expand Medicaid.
I always forget the second question. It's so annoying. Like I need to have a piece of paper and write it down. So it's political. And I'm sorry that I reveal my leanings when I present on the safety net because I'm very passionate. That's why I do this job. And I'm not Democrat either. I'm like just checked out of all this crap, but it's political. And you kind of got to understand it. So I think that the the perspective of states that choose not to expand Medicaid is that they don't want to pay for it and they don't think that they should be paying for people's health care. It's just their belief, and it is primarily like a Republican position that that's not the government's job. And so even if the feds are funding 90% of the cost for expansion for that population, they don't want to take it because they also don't want the strings. Because when you take federal funding, along with that comes a lot of federal rules, and they don't want to follow the rules of the federal government, especially under a Democrat administration. So it's just a difference of opinion. But you'll see that many conservative states have actually expanded Medicaid because they did the math and they saw their emergency rooms overrun by uninsured people. And the hospitals came to the legislature and says, we can't do this. We need to get paid for the services we provide. We have too much uncompensated care. You have to expand. So there's pressure from providers and the business community actually even to expand Medicaid because of what happens when you don't. So I'll just stop there. Hope that helps you.
Basically, do you think the safety net should be a safety net or no? That's why.
Do you believe in a safety net? Yeah.
Do you
And really,
think we should
there's
have a
people that
safety
don't.
net? People
Yeah.
don't. So
Yeah.
obviously we have a position on that, but it's for
Yeah.
people getting health care, doesn't matter where it's coming from. We just want people to get the care they need.
Yeah.
Can I have a comment real quick on the whole IHS federal agencies thing? I don't know if any of you were part of our summit in 2023, but we had a really awesome showing of delegates from our federal government, from HHS and ONC and all the acronyms, including Indian Health Services. And like Elizabeth said, they're all just people. They're all just like us. They're just doing their best at their job, trying to get people healthcare, trying to do innovation, trying to make the system better. And they want to be more involved with startup culture. They want to be more involved with what you're doing. And they know that not everybody knows what they're doing and what the resources are available to you as innovators and entrepreneurs. So reach out to NIH, their Seed Innovation Fund, and I can email you all some links after this too. ONC, National Coordinator for Health Information Technology. We have a contact there, Stefan Kanya, who is really wonderful and coordinates a lot of stuff. They want to be involved in this, and they want to fund projects, and they want to get pilots moving, and they want to get care to people. So reach out to them and you probably get better responses than you would think. It is a giant opaque system, but it is run by humans who have email addresses and want to work with you.
Awesome. Ryan, you had a question earlier that you're welcome to ask, but yeah, if you want the floor to ask the question or comment otherwise.
Yeah, thanks. Yeah. Just so people know, I put in a link. Basically, CMS has this provider services file. It's like 500 columns and like 150,000 rows. It contains very granular data on pretty much every single healthcare facility within the United States. You can get even like their fiscal years if they're a federally qualified health center. There's just a ton of data. It's very difficult to work with, but we ended up creating a sales dashboard from it, so we actually know going in, like everything about the facility, everything about the provider. So the link's in there if you want to take a look. My specific question is in regards to what are your Elizabeth, what are your thoughts on the challenges Medi-Cal will experience with the expansion of coverage to undocumented immigrants? I know they already covered children and those above, I think like 65, but now that they're expanding it to 18 years to 65, what are your thoughts on the challenges that they're going to see in the next, especially in the short term, the next 2 to 3 years?
I'm so glad you asked that question because it's really at the heart of me. And I actually worked on the legislation last year for Cover All Coloradans. So we're following California and we're expanding to undocumented folks. And so I've been working on this issue. And actually, I worked on the legislation 2 years ago where we started offering family planning services for undocumented folks. So I've seen I've been on the front lines. And you may already know this from the first expansions to undocumented folks, but undocumented people don't feel comfortable coming to the government for anything. They're often afraid of being deported for a good reason. And there's this whole rule called the public charge that happened under the Trump administration that basically said, even if you access benefits that you're eligible for, we could use that against you later, and let it be a reason that we don't grant you citizenship. And so that was like horrifying. And we undid it as soon as we could in the next administration, but the damage has been done. And a lot of people said it would be 10 years of damage, to let people know. So one of the things we're doing in Colorado, I'm sure California's done it, is trying to do an education campaign that you can access these services, you're entitled to them, and we're not going to use this information against you when you apply for citizenship. Another thing that's really important to let people know is that you're not going to share their they don't have a social security number, but let them know that we're not going to share their information with ICE, immigration officials. So what I've heard is immigrants don't even feel comfortable applying because they're afraid that their information is being shared. And then there's so many things. So there's the things that the agency, that the Medicaid application itself is a nightmare. And so, and it asks for things like your social security number. It asks for your citizenship. Are you a citizen? Questions like that, which are threatening. But they're federally required questions because under regular Medicaid, you can't get access to the program if you're an immigrant. So there's problems with how it's being administered. There's problems with immigrants even knowing that they're eligible for the services. So needing to do huge education in the community to let people know. And then correcting a lot of the myths that are out there that they could be in danger or deported if they share their information. So those are just a few of and cultural competency, right? This is all cultural competency. You got to know the audience you're speaking to. You got to speak to them, want to speak to them, and then you have to do it in a culturally competent way. And then you have to have an efficient way to enroll them.
And what are some of the, maybe even with your experience in Colorado, like what are the health systems concerned about, especially like let's say in Colorado, with having all of a sudden you're having a lot more people enrolled suddenly seeking care, like in a short term? Are they doing anything to prepare for that, or are there any concerns about like capacity issues, and like what are the conversations like, in your experience?
It's very rare that when you expand coverage to a new population that they all come and sign up and enroll and get services right away. So I wouldn't be. History it's proven that's not the case. There is the woodwork effect that they talk about, though, of people really who do sign up need a lot of care because they've not had healthcare coverage. So there is that. There is concern about having enough providers in Medicaid. There always is. I'm not worried about the health plans because you know what? They get a lot of money. Health plans are paid a lot of freaking money. That's where your money is. And they get money for all of those enrollees. The real strain is on your safety net providers. And we don't have enough of them. And you're exactly right, Ryan, that is an issue. And to the extent that you can figure out how to extend them through your solutions, and we can bring in paraprofessionals. And there's just workforce is the top issue right now, nationwide across health systems. And there's a lot of innovative things going on, but it doesn't freaking matter because we have baby boomers, they call it the silver tsunami, all coming in at the same time and needing a lot of healthcare. So we've got a huge problem in front of us, folks, and it is workforce. So sorry to leave on that note, but that's why we have you. Solve our problems.
Thank you so much, Elizabeth, for spending the last hour with us, giving us that broad landscape of our healthcare safety net. And yeah, just thank you so much. I appreciate it. And we'll let you go to whatever's next for you as we transition a little bit deeper into these topics.
Okay, well, I'm wishing you all good luck. I'm thankful that you're doing what you're doing. Keep going, and good luck in the challenge. And really go meet those providers. And health plans is where the money's at. And I should have said that more, but they have a real incentive too. So they're a good partner for you. Good luck, and nice to see you all. Take care.